Good evening. My name is Carrie Christopher Klein, and welcome to my reflection video on leadership and collaboration for the course NURS-FPX 4010, Leading People, Processes, and Organizations in Interprofessional Practice. The following are some of the things I intend to discuss throughout this video. I plan to reflect on an interdisciplinary collaboration experience, noting in ways which it was successful and unsuccessful in achieving desired outcomes. I plan to identify how poor collaboration can result in inefficient management of human and financial resources. I plan to identify best practice leadership strategies from the literature that would improve interdisciplinary teams' ability to achieve its goals. I plan to identify best practice interdisciplinary collaboration strategies to help a team achieve its goals and work together. And lastly, I plan to identify the strategy, its source, and reasons why I think it would be effective. I will make reference to the authors who contributed to the body of literature. The experience I will share will be during a collaboration on a wound care team within the institution I previously worked for. During this time, I worked for a large university healthcare system, and I worked in a level 1 trauma burn intensive care unit. I had formerly worked for this unit as a patient care technician for 5 years during nursing school. The unit has 16 intensive care beds, 6 of which of those can be used for floor status beds when necessary. Once I achieved my nursing license, I left trauma burn ICU, which I will reference as TBICU throughout the video, as a patient care technician, and I went to the medical surgical floor where I gained necessary nursing experience until I was comfortable with my skills. Once I was comfortable with my skills, I returned to trauma burn ICU. I was well known in TBICU by the veteran nurses for my wound care skills from when I was a patient care technician. I would always help the wound care team by choice, and it quickly became a passion of mine. I did wound care dressings by myself at times as they felt I could handle them on my own and could describe them for documentation purposes without difficulty. When I returned to the unit as a nurse, I then picked up where I left off and learned the role from a different perspective as a nurse. So today I will speak on an incident and the improvements that could be made within the scenario that applies to this project during my time as a nurse in trauma burn ICU. The scenario began when I received my wound care assignment for the day. We had 3 hydrotherapy room sessions booked for the day, 2 of which were with anesthesia providers and 1 with a conscious sedation nurse to be administered by our trained staff. This assignment alone would take a wound care team the entire shift from 7 a.m. to 3 p.m. With wound care assessments, turnovers, cleaning and onboarding anesthesia to the room. Usually these tub rooms were not the only wounds to be taken care of on the list of needs for the day, so stress was already high. The expectation in trauma burn ICU is that when a patient is down, meaning that the dressings are removed and the patient was washed in the appropriate soap mixture, the attendings would be paged to come assess the wounds bedside in the tub room. I had just returned to trauma burn ICU, and I was new to the role of the nurse on the wound care team. It was my responsibility to notify the physician when the patient was down. The collaboration fail was that I had paged the wrong attending. I had paged the previous week's physician rather than the wound care attending for that week. However, the attending I did page also never returned my page, so the anesthesia providers and I sat in the tub room waiting for a physician to show up and assess for over 20 minutes. Sometimes this wasn't uncommon depending on the physician or the day, or the number of wounds being taken down. Although there were heating lamps, the patient was getting cold, anesthesia was getting irritable as they had many more cases to complete, and I was as well, knowing I had a full list of other patients to see. This failed collaboration and communication here created inefficient management of human and financial resources. Time was a variance with the outcome of the patient. Time that the patient is not in dressings can create risk for infection. According to Ario and Olorunfumi, 2024, when layers of the skin are exposed, this can lead to increased rates of infection for burn patients. Uppaday and Smith, 2023, said the hospitals are incentivized or de-incentivized with pay for performance when it comes to healthcare-associated infections and the quality of patient outcomes. Therefore, the patient being exposed to the air for unnecessary amounts of time could create poor patient outcomes. I believe the best practice here would have been to follow up sooner than I did. This would have led me to find out that why we hadn't seen a physician for a wound care assessment in that 20-minute period of time. My feelings of anxiety directed my behavior as I was a new nurse in this role, and I didn't want to overstep my boundaries by repeating my requests to those that I felt were superior to me. In the literature, Hussein et al. 2018, it is discussed that leadership is when an individual influences a group of individuals to achieve common goals. I did not exude leadership in this situation. Since I was new, I did go to a colleague I felt most comfortable with and explained what was happening in the tub room. This colleague then helped bring to my attention the appropriate staff that needed to be notarized in order to get the wound care done. This colleague had leadership qualities, including intellectual and individual consideration, that made me feel comfortable addressing the issue. The charismatic leadership qualities expressed by this individual helped me not only explain what was going on, but also find the solution to the problem. As a unit, we explored changes to our collaboration, as some other nurses also experienced longer wait times in the tub room for different purposes. It was a widely known issue that coincided with my mistake. Changes were made and workarounds were created to solve this error, and our unit did implement these changes post-communication mistake. The change as a unit and as a wound care team was that we began to write the date and the wound care team members, including the attending and anesthesia providers, with the correct pager numbers for the week on the whiteboard in the room. This was to reduce communication errors by being obvious with intention for communication. It was the wound care members' responsibility to update the whiteboard each Monday morning post-huddle. According to Hussein et al. 2018, from the suggested reading literature, the 3 steps of Kurt Lewin's change theory were implemented. Unphrasing is the first step that happened without difficulty, as the cultural model of the business hospital I worked for, was to accept change in healthcare for evidence-based practices. Accepting change was one of the values of the organization. The awareness that a need for change exists in the healthcare continuum, and it was widely practiced and accepted by those that work there. The second step from Kurt Lewin's change theory that was implemented was that the actual change and the transition for our organization. This included many discussions about best practices for better outcomes and transition times for dressing changes and wound care assessments. The unit moved toward a new practice of writing the information on the whiteboard in the tub room for everyone to see. We then used the last step of the model, freezing. Once the change was discussed between providers and the best practice for better outcomes of the patients were addressed, the newly implemented communication tool was accepted and widely used by the members of the wound care team repeatedly for weeks until I left. In conclusion, Kurt Lewin's change theory was unknowingly implemented. Leadership collaboration was used to not only communicate the issue and solve the problem, but also to change the process of collaboration between healthcare providers to reduce risk and harm to the patients.